I'm Dr. Lalita from Nizam's Institute of Medical Sciences. Now we move to the other end of the spectrum of heart disease in women. And in the next few minutes, I would like to highlight important facts regarding the coronary artery disease in women. Over the past few years, especially in the last 5 to 6 years, there has been significant development in the field of women heart disease. There has been increased awareness. More women are being represented in trials and studies. Women-specific and women-centered trials have been initiated. In fact, the Circulation Journal has dedicated an entire issue to women heart disease. AHA has come up with its first scientific statement regarding acute MI in women. All this point out to the fact that CAD is no more limited to the men's arena. In fact, it is of utmost importance in women, and what more, it differs significantly. CAD is the leading cause of death in women and men all over the world. In fact, more women die of CAD, and this is more than all the deaths caused by the cancer. According to the National Center for Health Statistics, the symptoms of CAD are seen in 1 in 9 women less than 65 years, and this increases to 1 in 3 women after the age of 65. In fact, 90% of the women have some risk factor for cardiovascular disease, which is responsible for 1 out of 3 women deaths. That is, each 80 seconds, 1 woman dies. Among the deaths from CVD, 40% of the deaths are because of coronary artery disease. The prevalence increases exponentially, especially after the 6th decade, and the black race behaves the worst. What about the Asian Indian women? They have the highest burden of premature death. If you see, the incidence is 4.4% in the Asian Indian women, compared, which is itself is 2 to 4-fold higher than that in the West. And the mean age for presentation for the first MI in Asian women is 58 years compared to 70 in the West. According to Krishnan et al., around 19 crore Indian women have CAD. CAD has a bad impact in women, more complications, mortality is high, nearly 40 to 45%. Worse prognosis is seen in young women, especially young Asian women with MI. They face the higher risk of recurrence, heart failure, and death. The female-specific ischemic heart disease is the term suggested to explain the difference in the pathophysiology of CAD in women, smaller coronaries, less obstructive CAD, diffuse disease. Endothelial dysfunction and coronary microvasculature is of importance. This was proved in the ERIC as well as the WISE trial, and greater incidence of erosions and distal embolization, especially in the young female. The risk factors, nearly the same as in men. But what are the risk factors which are more predictive in women? Age 55 and above. Indian ethnicity itself is a risk factor, possibly due to genetic susceptibility. Premature CHD, especially a history of MI or sudden death in a sister less than 55 years, there is a 12-fold higher risk of CAD. Hypertension, a 4-fold increased risk. Obesity and physical inactivity are associated with increased death from CAD and all-cause death. Diabetes is a stronger risk factor in women than in men, with an incidence of CAD almost 3 to 7 times higher and a 4-fold increase in the heart failure. Indian women are found to have the lowest levels of HDL, less than 35%, and this gives an 8-fold increased risk of CVD. Triglycerides are of increased risk to women, especially more than 400. According to the Women Health Study, the single predictive of CAD is the total cholesterol to HDL ratio more than 5, which is seen in nearly 30% of Indian women, and it is the strongest predictor of CAD. Lipoprotein A is important for premature CAD and increases the risk of CAD by more than 100% when associated with the other lipid abnormalities. Smoking associated with 50% of the cardiac events in women. Autoimmune diseases, especially rheumatoid arthritis and SLE, are associated with increased CVD risk. Coming to the risk factors unique to women, early menarche, less than 10 years, ovarian dysfunction, early natural menopause, before 44 years, has been proved to be associated with increased cardiovascular risk. The role of parity, infertility treatment, and OCP is not very clear. Hypertension and diabetes in pregnancy, spontaneous pregnancy loss, preterm birth, all of them contribute to increased cardiovascular disease in later life. The Framingham risk score for assessment in women, especially asymptomatic women, is recommended, but it might underestimate the risk in women. So the Reynolds risk score has been developed specifically for use in women. And the 2007 update of effectiveness-based guidelines for prevention of CAD. This has recommended stratifying women into 3 risk categories: as high risk, those who already manifest the disease; at risk status, those who have more than one risk factors; and the optimal risk. What are the symptoms of CAD in women? Well, angina is the most common symptom in both the genders. However, women are less likely to have typical symptoms, typical angina. It is more induced by rest, sleep or mental stress. And stable angina is more common than MI as the presentation in women. Women who present with MI more frequently present without chest pain. Chest pain is absent in nearly 50% of the patient, and the most common symptom is dyspnea, and the prodrome is fatigue. According to the NRMI registry, 92% of the women presented without chest pain, and those who presented without chest pain were much sicker and had a worse outcome. Despite the similar clinical conditions, women are not referred as often as men for the appropriate diagnostic and therapeutic procedures. What should be the diagnostic approach for CAD in women? A clinical risk assessment, then perform a stress test depending upon the choice of the stress test will depend upon the clinical and non-clinical factors available and the expertise of the patient, expertise of the center, and most important is none of the non-invasive tests is perfect to diagnose coronary artery disease. There are a lot of pitfalls in these exercise tests. For example, the exercise test is less accurate, more of false positives, but the negative predictive value is high in both men and women. The Duke treadmill score is particularly useful in women and performs better in women than in men for predicting the significant CAD. Stress echo scores over the nuclear imaging and cardiac CT, possibly because of the risk or the fear of radiation exposure. However, in women presenting with stable symptoms suggestive of ischemia, coronary CT gives a much better prognostic information than the functional stressing. Additional testing can be considered depending upon the findings on the stress testing. ACS detection is with serial ECGs and high sensitivity troponins. One important fact is there is a need to adjust or need for a sex-specific cutoff levels for troponins because the baseline troponin levels are lower in women. The indication and recommendation for coronary angiogram remain the same. The significant CAD is less. Normal coronaries are seen in nearly 40% of the patients in stable angina and nearly 20% in the ACS. 20 to 50% present with cardiac syndrome X. And we should consider rare possibilities such as spontaneous coronary artery dissection, stress-induced cardiomyopathy, especially in women. CAD in young women, specific entity which differs from the classical CAD, normal coronaries, coronary erosion, poor outcome. Coming to the management issues, yes, CAD is undertreated in women. Possibly the most common cause is the low awareness among patients as well as physicians. Women are less likely to receive preventive recommendations. This undertreatment and less aggressiveness is also responsible for high mortality in ACS. This is confirmed from the international trials from Crusade, which showed that women with non-ST elevation MI were treated less aggressively and invasively. Women with ST elevation MI were also receiving less reperfusion therapy and catheterization procedures. Fibrinolysis in women. Women are less likely to receive it despite being eligible, and there is a great delay in being treated. Regarding the PCI, both genders equally benefit from early PCI in ST elevation MI. The outcome is similar with drug-eluting stents, but in non-ST elevation MI, there is a controversy. Invasive strategy is beneficial in women only with a positive biomarkers. Coming to CABG, the mortality rates are similar between both the genders. However, women are older, have more comorbidities, and more non-cardiac complications. Cardiac rehabilitation in women is especially underused. Management of non-obstructive CAD initially thought to be a benign, but now we know it is associated with high cardiovascular events, and the focus should be on symptom relief and by improving the vascular function. Most important thing is all women are at risk for coronary artery disease, and what should women do to reduce this risk? The first guidelines for preventive cardiology were in 1999, and they have been updated, and the recent 2010-2011 have all given emphasis to mainly lifestyle interventions: quit or do not stop smoking or do not start smoking, exercise regularly, maintain a healthy diet, may eat a healthy diet, and better maintenance of all the risk factors, that is high blood pressure, high cholesterol, and diabetes. It was seen that the most common cause of high mortality in women is the lack of awareness regarding the heart disease. Thanks to the International World Health Awareness programs, the awareness in the West has doubled from 30% to nearly 56%. And this has resulted in a 30% reduction in mortality among women in the West. But the same story does not hold true for India, where there is a lack of national registry for data in women. We don't have a complete organization, and specific mention of one of its own, that is the Wincar Association, being the first to spread the awareness on women heart disease. Coronary artery disease is the greatest health risk for women, and it is still under-recognized and undertreated. The risk factors are the same. However, women are more susceptible if they have diabetes, family history, or smoking. Gender-specific risk factors, especially the reproductive factors, should be considered in risk assessment. Women can present differently, and when they do so, they behave worse. Women present late and are referred late. They have more complications from the disease as well as from the treatment, but still, they do better than without treatment. So the need of the hour today is mainly awareness. It has definitely increased, but there is still a long way to go. Prevention is definitely better than cure. So at this stage, I think all of us should spread the message of feast, that is being with family and friends, eating a heart-healthy diet, having significant activity, stress reduction, and taking control of our health and the risk factors. Thank you.